welcome to the Home of Medicine podcast with me, Dr Amie Burbridge, a podcast in association with the European Federation of Internal Medicine. I'm an acute physician working in Coventry in the United Kingdom. And today I am incredibly honoured to be joined by Dr Sarb Clare, who is also a consultant in acute medicine in the UK. So Sarb, would you like to tell us a little bit about yourself and what you do?
Great. Thanks, Amie. And thanks for inviting me to join you on this incredible podcast. I'm really honoured. So as you've said, I'm an acute medical consultant, just like you. I'm also Deputy Medical Director at the Sandwell and West Birmingham NHS Trust, heavily involved in sort of developing and delivering our new hospital called the Midland Metropolitan, which will hopefully open next year. And really doing what acute physicians do, seeing and sorting our patients out.
Fantastic. Thank you so much for joining us. So today you're going to present a case to me. So over to you.
Yeah, let's kick off. So this is a case that was presented to me quite a few years ago, but really got lots of learning points, and hopefully we'll tease them out as we talk.
Great.
So this is a 19-year-old. She's an Asian girl, and she presents to ED with chest pain and shortness of breath, and she gets referred into medicine as an ACS. But she's 19, so things don't really fit in. So I'm listening to this story and thinking, okay. And the history really is not acute, it's chronic. It's been going on for 6 months, but it's not just chest pain and shortness of breath. Her symptoms are very much, she's tired, she's got a bit of weight loss, aches and pains, feeling dizzy, generally weak. Prior to this, she's been in ED several times with the same symptoms and dismissed. And prior to that, she's been to a GP at least 12 times, and she was told that she's got anxiety, she's depressed. A bit about her socially, she's working as a teaching assistant, and she says, I'm not stressed, but I've been labelled as having panic attacks. And as this case was being presented to me by the junior, there was a lot of, dismissal in the presentation as well. What are your thoughts, Amie, going forward?
So we've got a 19-year-old female with chest pain, shortness of breath, who was referred to you with acute coronary syndrome. But on further history taking, this pain's been there for 6 months. She's tired, she's lost weight, and she's got some general aches and pains. Now, my first thing whenever I see a female is she pregnant?
Yeah, absolutely. Yeah. And thankfully, she's not pregnant, no.
Okay, so I always say every woman is pregnant until proven otherwise. So do that pregnancy test and it's negative. So what's really interesting is when you're in the emergency department and a patient is referred to you, is how that patient is sold to you and how they're framed to you. So chest pain, shortness of breath, acute coronary syndrome, and you think, well, actually, she's 19 years old. So why was that diagnosis made on a 19-year-old? There must be something else that is possibly going on.
Absolutely.
She said been to the GP 12 times. What was the time frame she'd visited the general practitioner in?
So this has been going on now for 6 months, and she's back and forth. She was given, proposed to be given antidepressants and labelled as you've got anxiety, you've got depression. But when you dig deep, she hasn't got no hard symptoms of anxiety or panic attacks. But it's that labelling, and that label, interesting enough, continued, through her ED admissions, and she was dismissed.
And you often see that it's that diagnostic momentum where somebody's given a diagnosis very early on in their clinical pathway, and then it's very difficult then to get rid of that diagnosis. And I've also seen it in patients who are given a label of anxiety and depression, and they actually then do develop the symptoms of anxiety and depression because they're continuously told they've got it.
Yes. Yeah.
And it's like, oh, it must be then. So
yes,
I think we have to be very careful.
And the whole sort of young Indian Asian girl, it was the connotations with that, and the whole sort of, yes, she's got aches and pains, perhaps a bit of vitamin D deficiency, the usual. And that really, throughout my career, has, you have to really stop your juniors from labelling and that unconscious bias.
Absolutely, because I've noticed when you do also get a story from your junior doctor or a colleague who's presenting that case to you, they've also made a decision about the diagnosis, and they then sell that to you. And sometimes it's very difficult to question that diagnosis and to go back to the beginning.
And as you know, juniors, when they're presented to you, they're very forthright because they want to present to you that they're confident, they know what's going on, and they're very convinced that this is a diagnosis. And often I have to take a step back and think, okay, so let's rewind and start from the beginning.
And that's, I know when I was a junior doctor, I was definitely like that. I was like, it's got to be a PE. It must be, it fits. But actually, and it was really hard to, I'll probably still do it now, to be honest. It was really hard to take a step back because, you know, it's challenging sometimes to question your thoughts.
Yeah. And I think as juniors, you're very in that machine type mentality where you just want to get the diagnosis. But as we mature and we're more senior, you look at the whole picture holistically. Because one of the main things I always do is tell me about the social history, tell me what's going on at home, because that's where the jigsaw puzzle comes together. Yeah,
absolutely. So what happened next?
Yeah, so that was presented to me as, oh, this is all but nothing. You know, she's come in all these times. It's all but nothing. And it's like, so, okay. So I went to see her. She was put in a side room and I went deeper into the history. There was more to it. She was also having a mild fever intermittently. And that weight loss, it wasn't huge, but she was thin. She couldn't really quantify how much weight she'd lost, but there was something more going on. And interestingly enough, no one really examined her. No one examined her. And I said to her, okay, has anyone done a top to toe? But no, they hadn't. No one had listened to her heart, examined her chest, look at her peripherally, not even the junior doctor. So I examined her, and that's where I picked up some clinical signs. So I start off with the heart, and I found a murmur consistent with aortic regurgitation. So that's not normal in a 19-year-old. And she had a very weak radial pulse on the left side, which I could hardly feel. In addition to that, I did have some blood tests as well. As you can imagine, her troponins were negative. Her D-dimer was actually negative. Her bloods and her ECG was fine, but her bloods did show a raised ESR and CRP as well. So any thoughts? So we've got some raised inflammatory markers. She's got a stonking aortic regurgitant murmur in someone who's got some odd constitutional symptoms.
Did she have any night sweats?
Yes, she did. Yeah, a few night sweats.
Okay. You said she'd lost weight. How much weight had she lost?
Yeah, she couldn't really tell us, but she was incredibly slim. She was like sort of a size 6, but she couldn't quantify how much.
Okay. Any foreign travel?
No travel at all. No, nothing at all.
Okay. This is going to sound strange. Any changes in her hair? Had her hair been falling out?
No, nothing like that. So there was no features of thyroid issues or anything like that. No.
Okay. Any rash?
No rashes.
Okay. Joint pains?
Aches and pains in joints. Yeah.
Okay.
But there was no, on examination, there was no, arthritis or swelling or anything like that. But she did have some joint pain.
Okay. Any past medical history of note?
Nothing at all. Completely fit and well. And that's where it really was, she was really upset. And I felt so bad for her because these 6 months she'd been, having these symptoms, but was completely dismissed. And it was really eye-opening when I was actually the first person that had actually listened to her heart. And that was really disappointing because you just think, okay, because if somebody had listened to her heart 6 months ago, something would have been done.
Yeah. She had rheumatic fever as a child?
No, there's no features of rheumatic fever. Okay. But as you can imagine, so those in the audience, I'm a real POCUS enthusiast. Yes. So point of care ultrasound. Yeah. So on my post-8 ward round, I got out the ultrasound because she had this 19-year-old with a stonking aortic regurgitant murmur. The first thing you want to think is, have they got endocarditis?
Absolutely.
So I put the probe on and she had a severe aortic regurgitation. but she didn't have any vegetations that I could see.
Okay.
And I also scanned her aortic arch, and that was essentially dilated. And we did some other bits and bobs as well. So she definitely had a very weak left radial pulse, but there was no significant differences in her blood pressure. So that's where we got to.
Okay. Was there any family history of any rheumatological conditions?
No, there wasn't. No.
Okay. So I do have a diagnosis in mind, but it's incredibly rare. And so I'm thinking sort of along the lines of Takayasu's aortitis.
Well, there you go, Amie, you've cracked it in one.
Oh.
Absolutely. So I was incredibly proud that we diagnosed Takayasu's arthritis on the post-8 ward round in acute medicine.
Yeah.
So, absolutely right. So this is somebody who's young, female, has got some constitutional symptoms. She's got this murmur. She's got this weak radial pulse, but had sadly and unfortunately been labelled with anxiety and depression. And she carried on with these symptoms. She reattended and attended, and still no one listened to her heart, because that gave her away, really. No one actually listened to her, the story. So for me, it was that it's about stripping it back to the basics. And the audience may say, oh, well, that's all very fancy that you did an ultrasound at the bedside and stuff. But actually, we didn't need to do that. Let's strip it back to the history, go back to the basic examination, and you can put them together, especially with the raised inflammatory markers as well.
And I'm a massive fan of history taking. Osler says, listen to your patient, they are telling you the diagnosis.
Absolutely.
And, if you take a really good structured history, and it can take time to do that, and sometimes it is difficult, patients will often say, I've already told 3 doctors this today. And it can be frustrating for them. But often we ask questions maybe slightly differently, you get different information. So taking a history will often give you that diagnosis or ideas, and the examination will help to confirm that. And actually, all these fancy investigations, do we really need them all?
Absolutely. I mean, she goes on to have a CT aortogram and TOE and all sorts, which, puts all the diagnosis together. But, within that post-8 ward round, we'd put it all together. A young girl, raised inflammatory markers, she's got AR, dilated aorta, weak radial pulse. This is Takayasu's. And her symptoms fitted in with that, with the sort of, their sort of constitutional, the dizziness, the aches and pains, the fevers. Really, really interesting case. Yes, it's a rare diagnosis and it's really fancy. However, for me, it really stripped it back to the basics, history and examination. And really important not to dismiss our patients.
Yeah, absolutely. I think we certainly, when you've got individuals who are frequent attenders, they're often labelled as difficult individuals, or there's nothing wrong with them, or they've come in with something silly. But actually, sometimes you go back, like you say, to basics and then take that history, because the problem is, with this individual, there are so many cognitive biases that were in this case. As soon as she walked in that door, she's young. She can't have anything wrong with her. She's young.
Yeah.
She's 90.
To the point where they don't even examine her, because you're 90, you don't need to examine you. Whereas if this was a 50-year-old, we would have done a top to toe.
It's really interesting, isn't it? And also, if somebody had seen Takayasu's aortitis before, they may have thought about it.
Yes.
But it's, but sort of thinking, well, I've seen this before, that hindsight bias. But actually, it's a really interesting on how we approach the younger patient compared to the older patient.
Well. And as you know, because we've worked together at City, a lot of our patients are all young, and we have lots of regular, attenders. And, I think as us as seniors, we have to be the one that takes our juniors out that vicious circle and say, look, stand back and look with your big lenses on what's going on with our patients, because there's always a reason why they're coming in. And it is, and as you say, it's all there in the history. The patients will give you the answers.
Yeah. And sometimes the reason they keep reattending may not be because it's a medical problem, but it might be through to challenges at home.
Yeah.
So, I've seen individuals come in frequently because they've got no central heating, or they're having issues with their pets, or, it can be these things that actually there is something going on. It might not be medical, but it's still something that we need to find out and address and really look into. Absolutely.
Yeah, fantastic.
So with this individual then, what was her course? What happened next?
Yeah, so she went on to have a formal echocardiogram. She went on to have a CTA aortogram, which essentially showed, features of Takayasu's. And she started on methylpred and a cyclophosphamide, and she's done really well. She's under the rheumatology team, being monitored. I've seen her pop up a few other times with other things, but it's because we go back to when she first got diagnosed, when she was 19 a few years ago. So she's doing really well, but she's on immune suppressants for her illness.
How do you think the role of the focused ultrasound that you did then maybe changed her management at that particular time?
Absolutely. So, I mean, as you know, I'm a huge enthusiast and fan and champion of point of care ultrasound. What it does, it enables you as a clinician to deliver a diagnostic right at the bedside. But more importantly, you are getting the diagnosis there and then. So let's say I wasn't able to do that, I would have to order an echo, and the echo could possibly be done that day, the next day, or 3 days. So it would have delayed that diagnosis. So for the patient, it was brilliant because she got to see me doing a diagnostic there and then at the post-take ward round. And I told her, you've got a leaky valve, or we need to find out why that's going on. So she got her answer there and then. So anxiety, diagnosis, length of stay, the patient journey, absolutely improves that. But more importantly, I would say for any clinician, whether you're acute or generalist or intensivist or a general practitioner, this is a skill that really empowers you to be the best clinician that you can be, because you are able to execute a diagnostic and answer a question. So for me, it was, I was thinking, has she got endocarditis? Yeah. Is there vegetation? Because why has a 19-year-old got severe AR on auscultation? And, what it gave us is she didn't have endocarditis, but she's got something else.
Yeah, it's certainly something that I can't do, point of care ultrasound. And it's I think a big failing of mine, actually. And it's something that I want to learn. So I'm going to make a conscious effort this year to do POCUS. Yeah. Definitely, because I think it's so important, particularly as an acute physician. I should be able to do that.
Yeah, and the brilliance of it is the portability of that. And what I will say is that during COVID, it was absolutely invaluable, because we were diagnosing COVID-19 at the bedside. We didn't have to take patients to CT. We were triaging them, getting in the right streams. But also these patients, they had no relatives, no one to see, but they had us in our sort of spacesuits, and they could see. I could tell them, look, your lungs are getting better, because look, you can look inside your body and look, it's getting better. So
amazing.
It was really, and I think COVID-19 has really put real emphasis on POCUS, that it's a tool that we should all be gaining. And if you look at medical school now, we're still teaching, 18th century medicine. We need to move with the times. IT has progressed. In America, they're giving out point of care ultrasound, for all medical students, and they've got them, so they're actually applying it now. So I think in a few years' time, and I know it's going to happen, is our medical students, when they come out, they'll be more proficient than us.
Yes. Yeah. Do you think it will replace the stethoscope?
Absolutely not. No. I don't think it should, because a stethoscope is your first indicator. Like in this case, I listen to her heart. Okay, she's got a murmur. Now I will scan. So the stethoscope, we need that for your wheeze, listen to crepitations. And then the ultrasound is, I always describe it as the icing on the cake, because the stethoscope, your history, your exam, your stethoscope, that will guide you. Do you need to do a POCUS scan?
I've got a trainee who I work with at the moment who's fantastic, and she's got this brilliant machine that she carries around with her in like a pocket, and it's incredible. And I'm embarrassed that I don't have that skill, and it's something that I really need to take on board and really learn over the next couple of years, because I think that will really change the way I practice.
And what I would say to yourself and the audience is that it's not a difficult skill, because we're not going to be radiographers or echocardiographers. We are just asking a simple question. Is there consolidation? Yes, no. Is there fluid? Yes, no. And as I said, it will empower you as a clinician, and you will be able to deliver the best care possible. I mean, I can't live without it. And it's been one of those sort of, once you do it, you never go back.
Yeah, I definitely need to do it. So this has reaffirmed that decision in my mind that I need to do that this year. Absolutely. So we have a patient with Takiesu's arteritis then. So just a little bit on the physiology, I guess. So we know that it's a vasculitis of the large vessels, tends to affect the aorta and its primary branches that come off the aorta. Tend to see it more in women, and it's usually diagnosed before the ages of 40 as well. Typical symptoms are, on exertion, you might get some claudication in the limbs. So it tends to be the upper limbs. You might get chest pain, and that's certainly something that this individual had. Weight loss, she had that. Fatigue, she had that. Low-grade fever and myalgia, all of which this patient had. Examination-wise, you can sometimes get bruits over the carotids and the aorta, but it's one of those things that I have to say I don't really, again, listen to that often. So again, it shows that importance of examination. So Takiesu's aortitis, as you said, is quite a very, very rare condition, and you'll probably see one or two in your lifetime of sort of diagnoses. But we know that it's immune mediated, so you've always got that antigen antibody complex formation that is happening within the large arteries, and we know that it's probably interleukin-6, one of our pro-inflammatory cytokines, that is actually driving that. So management-wise, we talked about glucocorticoids. And in this individual who's only 19, lifelong glucocorticoid usage can be quite problematic, can't it?
Absolutely. I mean, for her, because when I've seen her again, she's not the 19, very thin, slim girl she was. Yeah. She's got moon face. She's definitely overweight, and for someone so young, it's not great. And also, just let you know that as time has gone on, she's now developed narrowing of her left renal artery as well. So keeping very close on a renal function and so forth. So it's a lifetime of medication for her.
Yeah, and also because she's immunosuppressed, she's going to have the increased incidence for the infections, but also you've got the hypertension, osteoporosis, the cataract formation. I mean, and also I guess with the aortic regurgitation, could be congestive heart failure a lot earlier than potentially she could have. And I guess there'll be some implications for pregnancy as well.
Yeah, and I think they're discussing at the moment about stuff like anti-TNF agents and biologics with her as well. And they are having difficulty tapering down the steroids because she's been on them so long.
That is a real challenge, isn't it? Absolutely. Fantastic. Thank you so much. That's been a really, really interesting case. And I think it highlights such important biases that we are faced with every single day. And we really need to question ourselves every time we see a patient, and every time we make a diagnosis is to question that diagnosis. And question it and question it and question it.
Yeah. And it's interesting because we talk about challenge, and as a senior doctor, we want our juniors to challenge us because it's so important. But when you've got to be on high alert as well when your juniors are pushing you to go down one pathway. So you always have to be in a certain sort of space of mind and think, okay, no, it's not that. Let's go back. Let's go back. So I would say our juniors should be challenging us every day.
Absolutely. And I think the difficulty is when that's the 40th patient you may have seen that day, or you're really tired. And then that's when the challenge comes, isn't it? is actually sometimes you feel like you don't have enough time, or you're tired, or you've been up all night with a screaming baby or whatever. Yes. And it really does affect how you work.
Oh yeah, absolutely. And you know the situation at the moment, we come on to, there's 15 patients bedded in ED, ambulatory care is bedded, and you've got 40 patients plus to see. You have to decide, who are you going to examine? Who are you not going to examine? Who are you going to take a deeper history? Or you're just going to go with the flow? And that can be very, very difficult and very challenging, because the responsibility lies with you.
And that's something I haven't mastered yet. I've been a consultant only for a few years, and I still struggle to be, I guess, to triage who I need to spend more time with or less time with. And I feel quite slow, actually.
But I think it's really difficult because of the ever-changing junior body as well. It's about that trust, who we know the juniors you can trust, and I don't need to even, lay a hand on. Yes, that's absolutely fine. But then there's something in the history that doesn't make sense. And that's where I think, okay, now that's my trigger. I need to go back.
Mm-hmm. So it's that gut instinct, isn't it? Yeah. You're listening to something like, oh, that doesn't sit right. And often it's difficult to explain why it doesn't sit right. It just doesn't sit right. So you then have to delve a little bit more. Yeah. Absolutely. Fantastic.
Yeah, thank you. Great case. I think hopefully the audience will see how, biases have come in, how a patient was dismissed for 6 months, but also the power of what you can do by simple history examination and this utility of POCUS.
Yes, absolutely. So the key thing today is go back to basics. Go back to that history, chat to your patients. Absolutely. Thank you so much for that.
Thank you for having me, Amie.
That's an absolute pleasure. And if anybody's got any questions, you can email at amie@efimacademy.org or tweet me at Amie Burbridge. Thanks for listening. Goodbye. You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.